Alright guys, this is Mr. H again with NCLEX, and today I'm going to be discussing gastrointestinal medications, okay? So before I jump in, let's get some things out of the way. We have two main cells inside the stomach that produce acid or help with the activation of acids. It's going to be your parietal cells and your chief cells. And to start off, the parietal cells are responsible for secreting hydrochloric acid and intrinsic factor. And then your chief cells are responsible for secreting pepsinogen and chymosin. Now these are precursors to acids. So in essence, the chief cells, when they release its pepsinogen and it meets with the other hydrochloric acid in the stomach that the parietal cells have already secreted, it activates it, and now we have pepsin, and pepsin is the actual acid. I want you guys to also remember that the pH, when it's acidic, the pH is down or low, and when the pH is high, it's more basic or alkaline, so keep those things in mind as well. Regarding the parietal cells, the hydrochloric acid and the intrinsic factor are really important, because what do we need intrinsic factor for? It's for the absorption of B12, right? And without that, we develop pernicious anemia and things like that. So make sure you guys read up on those basic elements, guys, because it's going to help you guys out when you start understanding the pathophysiology of a lot of other disorders as well. So let's get into it. First of all, we have antacids. Antacids mainly work by taking the medication, and it neutralizes the acidity already within the stomach. It doesn't really activate too much work on the actual cells, but some of these drugs do have an effect on the muscle tone, whether it excites it or it depresses it. So let's begin with the action of antacids. They neutralize the gastric acid and they inactivate pepsin, which means that it's pepsinogen only and it won't become acidic. Some medications included are aluminum hydroxide or Amphagel, magnesium hydroxide, milk of magnesia, and sodium bicarbonate. Well, let's talk about aluminum hydroxide. Any medication that's based on aluminum, you have to remember that it suppresses the gastric motility. So it may lead to constipation. At the same time, it may lead to hypophosphatemia, because some of these medications, when they start exerting their effect on the mucosal linings, we have an issue with the absorption of certain elements like calcium, let's say, and it starts destabilizing the calcium-phosphorus relationship. And in this particular case, it may cause hypophosphatemia. We have magnesium hydroxide or milk of magnesia, MOM, and some side effects of this one include diarrhea and hypermagnesemia. Now, hypermagnesemia means that you have excessive amounts of magnesium, and what you guys have to know about any magnesium-based medications, including milk of magnesia, is that it increases the gastric motility. So if your aluminum hydroxide decreases gastric motility, it may cause constipation. Well, if magnesium excites it, it may cause diarrhea. So diarrhea is one of the side effects of milk of magnesia. You have to take precautions when giving any type of magnesium-based medications with people who have kidney failure, because it won't release it and it'll cause metabolic instability. And we also have sodium bicarbonate. You guys should remember that bicarbonate or base is the opposite of acid. So we take the medication and it neutralizes the acidity. So some therapeutic uses, of course, are PUD or peptic ulcer disease, and GERD, gastroesophageal reflux disease. This is a condition, a chronic condition, where the acids in the stomach cannot be contained within the stomach, and it refluxes back beyond the lower esophageal sphincter or the cardiac sphincter, and it erodes the esophagus, and you may develop Barrett's or Barrett's syndrome or Barrett's esophagus, and it's just a lot of denuded parts of the esophagus or ulceration. So we give these drugs to neutralize the acidity. Some nursing intervention and client education, which is your guys' role. Do not administer to clients who have GI perforation or obstruction. Well, you guys got to remember, aluminum hydroxide or aluminum-based antacids, they decrease the gastric motility, right? So if you have an obstruction and you're giving this drug, you're going to further exacerbate the obstruction, and you may force an ileus or a very serious obstruction. You have to be careful with anybody that already has GI perforation, because if they're already having a hole, an ulcer within the stomach, and it's perforated, it's going to exacerbate the issues as well. Clients who have renal impairment should only use aluminum-based antacids, because again, if you use magnesium-based and you have kidney impairment and you can't get rid of the magnesium, it'll cause metabolic instability. And then other medications, any other medication, should be taken 1 hour before or 1 hour after the antacids, because the medications that are prepared by pharmacists, by the pharmacy industry, they're made understanding that there's acids inside the stomach, and so they're supposed to be broken down a certain way so they can be released accordingly in the small intestine. But if you're taking antacids, you're no longer having the ideal acidic environment in the stomach that the pharmaceutical companies have in mind when they make the medications, and because of that, it may alter the absorption of the drugs. So be careful with that. In particular, antibiotics or like anti-seizure drugs or any drug that requires a therapeutic value, you can't be taking them. But generally speaking, all medications should be taken 1 hour before or 1 hour after the antacid medication has been given. And require repeated doses up to 7 times a day to help with the acid neutralizing capability. It can be 1 hour and 3 hours after meals and at bedtime as well. So because of that, make sure that you understand the patient teachings, because that's what you guys as the nurses are going to be giving the patients. Let's move on. So anti-secretory or blocking agents, we're talking about proton pump inhibitors. Now, the proton pumps are generally speaking on the membrane of the cells that release these acids. And there's different mechanisms that we can actually interfere with so the acids will not be released, or at least the catalyzing agents like the enzymes that, like for instance, pepsinogen is being released so it can be activated by the hydrochloric acid to become pepsin. Well, we can block those type of effects, and that's what the proton pump inhibitors are doing. Prevent or block selected receptors within the stomach, and the therapeutic uses include, of course, gastric or peptic ulcers, GERD again, and Zollinger-Ellison syndrome. This is a condition where somebody develops tumors within the lining of the stomach where the cells are located that release acids. And you guys have to understand that tumors, fast dividing cells, so it's gonna prompt or increase the release of the acid, and it's gonna lead to gastric ulcer disease. So because of that, we can give it to patients who have Zollinger-Ellison syndrome as well. So let's start off with the proton pump inhibitors. We have the generic and we have the trade names. Please know the generic names. You will also hear like Prilosec, Nexium. I've seen commercials on both of those drugs. However, you should understand that proton pump inhibitors, they end in prazole. So we have omeprazole, pantoprazole, we have esomeprazole, we have robeprazole, and we have lansoprazole. So all these drugs, folks, end in prazole. If it ends in prazole, you know it's a proton pump inhibitor. Some precautions and interactions. Well, omeprazole promotes increased risk for infection. How is that? Well, the acids are supposed to get rid of any bacteria that enters your alimentary canal. And if you're neutralizing acidity, it's no longer highly acidic, hence any bacteria that may become pathogenic, meaning can cause disease, it will thrive, it will survive, and it'll go inside and it'll cause pathogenesis, or it'll actually make you sick. So that's why it's talking about the infection. And it says use with precaution or caution with COPD patients. Now, I've read about that. They did a study in Taiwan where they looked at different groups of people from like 2001 to 2005. And statistically speaking, they found out people that have a chronic use of proton pump inhibitors, they were getting a lot of pneumonia. So because of that, you have to take it with special precautions with people with COPD, because the COPD, you have an excessive amount of mucus. The mucus actually gets in the way of the gas exchange, but it also prevents the patient to be able to expectorate. So I believe, statistically speaking, based on the research that I've read, of the studies that I've read, people develop pneumonia when they have COPD and they're taking proton pump inhibitors versus other control groups that weren't experiencing those essential elements. So because of that, make sure you guys teach your patient about that. Digoxin levels can be increased with omeprazole. So omeprazole, that medication again, omeprazole, you have to be careful because the acids are also supposed to break down the medication or the drug byproducts, the metabolites, so they can be excreted effectively. But if you start neutralizing the acid, or you start decreasing the acidity of the stomach, well, some elements that those acids are supposed to break down so your liver and kidneys can eliminate them and excrete them, well, it's not happening anymore. And because of that, statistically speaking, we're finding out, based on the studies, that digoxin levels can be increased, so it may cause digoxin toxicity for anyone who's taking proton pump inhibitors, in particular omeprazole. So make sure you guys educate your patients about that. Long-term therapy has increased risk of gastric cancer and osteoporosis, and I've read the studies on that too. They don't really know why it happens, but again, statistically speaking, people that are taking long-term therapy of proton pump inhibitors, they're inhibiting a natural course of physiology of the gastrointestinal tract. And because of that, it messes, from what I've read, it actually messes with the calcium release. It affects your parathyroid hormone. So as a idiosyncrasy, as a thing that ends up developing later on, osteoporosis and gastric cancer usually develops as well. Some side effects and adverse effects of the proton pump inhibitors include low incidence of diarrhea, but it does happen, nausea and vomiting. It can increase the risk for fractures because we already discussed osteoporosis, right? So it may cause fractures or pathological fractures, pneumonia, and acid rebound. With these medications, we're preventing these cells from doing what they naturally do. So because of that, sometimes as a compensatory mechanism, they start releasing way more acid because they notice that their acid production ability is being suppressed. And in some patients, you have them have hypersecretion of acid again, so that's why it's called acid rebound. Nursing interventions and client education: do not crush, don't chew these medications, don't break down any of the tablets, and that's important for you guys to educate your patient about. Notify the prescriber of any signs of GI bleed, and reinforce client teaching to take medications as scheduled. These are the elements that you're going to be discussing with your patients, folks. Make sure you guys really emphasize the things on do not crush or chew or break tablets down. Get that concept, because there's different ways that they can set a question for you to try to trick you to see if you know what you're supposed to do and what you're not supposed to do. Let's move on. Now, histamine 2 receptors. Histamine is an element that's needed for the production of acid. So what we do is we block the histamine 2 receptor, so the body can reduce its acid production. Don't confuse this with the histamine that we describe when you have like allergies. It's the same element, histamine, but it exerts a different effect in the GI tract. So medications, all the medications that are H2 receptors blockers, they end in tidine. So we have ranitidine, we have cimetidine, we have nizatidine, we have famotidine. These medications, folks, are all histamine 2 receptor blockers, and they exert the same conceptual mechanism, meaning they slow down the acid production. So they can cause toxicity for clients taking Dilantin or phenytoin, Coumadin or warfarin, theophylline, and lidocaine. So be mindful of that. People that are taking the tidine medications, the H2 receptor blockers, it can cause toxicity. For your patient taking Dilantin, if your levels go too high, you can have some CNS issues. You can actually depress the respiratory effect. You can depress the cardiovascular effect, the cardiac rhythm. So you have to be careful with that. Toxicity of warfarin, of Coumadin, the INR will go up. It'll potentiate bleeding. So you have to be careful with that. Theophylline or aminophylline is a bronchodilator. You have to be careful with that as well. And you guys should memorize or should know that the theophylline serum value, it should be 10 to 20. And we'll discuss that more in respiratory disorders. And then lidocaine. Any of these medications, folks, can become toxic when you're taking any of these H2 receptor blockers. So be mindful of that and educate your patients about that. And that's why you have to take a thorough history so you can make sure that you educate your patient accordingly. Cimetidine promotes increased risk for infection. Same concept that I discussed when I was talking about the other antacids. And use caution with COPD. Same concept, folks. Side effects and adverse effects. Well, it can cause a decrease in libido, meaning your sexual drive, or it can cause impotence. Lethargy, depression, confusion. And nursing intervention and client education includes clients should seek appropriate care. Many take over-the-counter preparations, so you want to make sure that the patient always discusses their history of medications that they're taking with the practitioner to ensure there's no particular interactions. Clients should follow medical regimen. Ranitidine can be taken with or without food, and reinforce teaching with the client to modify the diet as prescribed. We're essentially going to be decreasing the elements that cause more hyperacidity, folks, and you got to be able to educate your patient about those elements. Now, all the medications that we've been discussing prior to this have been to prevent an ulcer, or for the prevention of the perforation of an ulcer. Now let's discuss what happens when the patient already has an ulcer, and we got to give them a different classification of drugs. So We have our mucosal protectant drugs. These ones are given when somebody already has damage to the mucosal lining, and this medication coats it, and it prevents the acid from injuring the already created ulcer. So the medication is sucralfate, also known as Carafate. Action is it adheres or it sticks to the injured gastric ulcers upon contact with gastric acids. Protective action for up to 6 hours, and it has no systemic effects. So that's the beauty part. When we discussed the antacids, some of them had systemic effects, like the issues with osteoporosis, but with these ones, no. They have no systemic effects. Therapeutic use, we use it for gastric and duodenal ulcers. We use it for GERD, and some nursing interventions in client education include administer on an empty stomach at least 1 hour before the meal. So again, you administer on an empty stomach at least 1 hour before the meal, because the medication has to go inside and it has to coat the already created ulcer so it can protect it. These are also known as cytoprotective agents, by the way. And do not administer within 30 minutes of antacids. When it comes to antacids, we already mentioned that we should not be giving them with any medications, including these ones. You want to separate them. Do not give them at the same time. Let's continue. Now, these medications, we're talking about patients who have nausea, who have vomiting, and we can give antiemetics. So the antiemetics, the action is, well, there's multiple classifications of medications that affect the GI tract or the vomiting centers in the brainstem to reduce nausea and vomiting. So the therapeutic use, of course, any patient that just came out of surgery, they had a lot of different drugs, including propofol, the anesthetics that, of course, are bringing the patient back to life in essence, they're gonna have nausea. They may vomit, they may have aspiration risk. So because of that, your post-operative patient, we're gonna be giving them antiemetics. People that are receiving chemotherapy. Chemotherapy drugs are medications or toxic cocktails that reduce cell division all throughout the systemic body, which includes the decreasing production of mucus. And the mucus is there, of course, to protect you. And if you have a lack of mucus, the acids and the elements within the body are going to be irritating the stomach and maybe causing nausea and vomiting. So because of that, we can give antiemetics after chemotherapy as well. And for any patient experiencing nausea, vomiting associated with any particular disease process, that's what the antiemetics are for. Let's talk about some of them now. So, we have promethazine. You guys have probably heard of promethazine. A lot of the rappers are talking about codeine and promethazine because it causes drowsiness, meaning it suppresses the central nervous system. It's suppressing the parts of the brain where we have the nausea and vomiting centers, so the patient will decrease its nausea and vomiting tendencies. So drowsiness, extrapyramidal symptoms. This is really important, folks. Make sure you understand this concept. The EPS are extrapyramidal symptoms, signs and symptoms that the patient will manifest outside of the ordinary, outside of something that you would ordinarily expect. So we're talking about tremors, abnormal movement, things of that nature. Does that make sense? It's a ghost in here. Wow, look at that. Oh, there's a fly. So anyway, they also promote anticholinergic effects. Anticholinergic effects decrease, or they dry you up in essence, but they decrease the mucosal production of the intestinal tract. It potentiates effects when given with narcotics, meaning if the narcotic is a CNS depressant, and we're giving promethazine, which is also essentially blocking or suppressing the nausea centers of the brain, well, it's going to potentiate the narcotic effect. You got to be careful. It may drop the respiratory rate. It may drop CNS function. Some nursing interventions monitor vital signs, and if you have to give it IM, intramuscularly, you want to use large muscles and take safety precautions. Any drug that you're giving that's suppressing the CNS in every fashion, shape, or form, safety precautions become priority because the patient may injure themselves. Metoclopramide or Reglan. This drug, same thing, drowsiness. It may cause extrapyramidal symptoms. These are the things that you guys are having precautions for, meaning you're observing your patient. If the patient suddenly develops some tremors, you have to report that. Those are the extrapyramidal symptoms. If they have a movement of the leg that can't stop, you have to report that. That's an extrapyramidal symptom. They also can have anticholinergic effects. Any patient that develops anticholinergic effects because secondary to a drug, they're at risk for urinary retention, constipation, dry mouth. Make sure you guys understand that. You may develop Tardis Dyskinesia. Now, Tardis Dyskinesia is a permanent extrapyramidal symptom. It doesn't necessarily affect your cognition, but you will have the lip smacking, the involuntary movement of the body. That's what Tardis Dyskinesia is. And you also may develop restlessness. Any of those elements that you guys see your patient exhibiting or manifesting after they take metoclopramide Reglan, you have to report it to the practitioner because we want to prevent Tardis Dyskinesia. And some interventions in short line about rapid GI emptying, meaning this drug, what it does is it speeds up the gastric emptying, the gastric dumping, so the food won't stay in the stomach, so you'll have a less chance of actually becoming nauseous. And discontinue the medication whenever you have any signs and symptoms of the EPS, the extrapyramidal symptoms, which mean involuntary movement, inner restlessness, akathisia, things of that nature. Make sure you guys look up these words. Zofran is a very common drug, folks. It's also known as ondansetron, and some headaches may develop, some extrapyramidal symptoms. You guys notice that all these antiemetics, because of their effect or the way that they exert their effect on the CNS, the patient's at high risk for EPS. So make sure you guys understand that. Nursing interventions include administer tablets 30 minutes prior to chemotherapy and 1 to 2 hours before radiation. Radiation and chemotherapy, even though they both have different mechanisms of actions, they both essentially do the same thing. They slow down cell division, and if that's happening in the GI tract or anywhere the radiation and chemotherapy are exerting its effect, the patient will become nauseous. We want to make sure that we give any PO tablets at least 30 minutes when it comes to chemotherapy or 1 to 2 hours when it comes to radiation. Scopolamine, blurred vision, anticholinergic effects, and sedation. Those are the side effects of these drugs, of scopolamine. Now listen guys, I want to emphasize this whole blurred vision, anticholinergic effects, because when we talk about anticholinergics, generally speaking, anticholinergics are contraindicated for people that have glaucoma, in particular, closure angle or acute glaucoma. So in the nursing interventions, it says do not use with angle closure glaucoma. That's because these symptoms of anticholinergic effects, these side effects of anticholinergic effects may increase your intraocular pressure. So if some patient comes in and they have a history of glaucoma, in particular acute or angle closure glaucoma, these medications are contraindicated. So do not use with angle closure glaucoma. Apply transdermal patches behind the ears, and also use lubricating eye drops because it may cause blurred vision and the patient's going to have a hard time with lacrimating or lubricating their eyes, because what did I say anticholinergic effects carry out? They dry you up, so the patient won't have a lot of tears. So because of that, we use artificial eye drops or lubricating eye drops. I hope that makes sense. And then we have anti-diarrheal. So I want you guys to think about this. If somebody's having diarrhea, what's the intestinal motility? Is it fast or is it slow? You should have answered fast. So what do these drugs do? They suppress it. So they activate opioid receptors in the gut, folks, in the GI tract to decrease intestinal motility and to increase the absorption of fluid and sodium. Now we're talking about electrolytes, fluids and electrolytes in the intestinal tract. So I'm going to say that again. They activate opioid receptors in the GI tract to decrease intestinal motility and to increase the absorption of fluid and sodium in the intestines. What ends up happening is, I want you guys to think about this. Your patients who are taking opioid analgesics, what are they at risk for when it comes to the GI tract? Constipation. They slow down the GI motility. So these anti-diarrheals, they exert their effects in the opioid receptors within the gut, so they can slow down gastric motility, movement, so you'll decrease the diarrhea, the chorro, right? Medications include diphenoxylate plus atropine. Atropine, again, you have diarrhea, you want to dry up the mucous membrane right now, and that's what Lomotil does. You also have loperamide or Imodium or Imodium AD. You guys have probably heard of that as well. Some precautions. Well, there's increased risk of megacolon, because a megacolon means that you have an ileus, a blockage, and the stool impacts the colon and it gets huge, right? Megacolon. That may happen when you decrease the gastric motility. So increased risk of megacolon for clients who have irritable bowel syndrome, may cause drowsiness or dizziness, and nursing interventions include monitor for fluid and electrolyte imbalance, because now we are interfering with the fluid and sodium exchange. And avoid caffeine intake, because caffeine gives you bubble guts, right? It increases gastric motility. It will counteract the effects of the anti-diarrheals that we're talking about here, your Lomocil, your ammonia. Now let's talk about stool softeners. Stool softeners are a medication that you guys are going to be giving to patients frequently. Not only for patients who are at risk for constipation, but think about your post-cardiac patients. If your patient just came back from surgery and they have, say, a cabbage procedure, the last thing you want them to do is to bear down, because if they bear down, they activate the vagus nerve. If the vagus nerve is activated, you're activating the parasympathetic nervous system. And if you activate the parasympathetic nervous system, you're decreasing the heart rate. And right now, for your cardiac patients, you don't want to do that. So keep that in mind as well when we're talking about stool softeners or laxatives. So the first one is psyllium. Therapeutic also known as Metamucil, by the way. Therapeutic uses decrease diarrhea. They increase the bulk forming capability. So in other words, what ends up happening is they pull fluid into the intestinal lumen so we can soften up the stool and create bulk and we can poop it out. We also have Docuset sodium or colace, and that therapeutic uses is to relieve constipation, surfactant, the lubricating component of the intestinal tract, so the stool can pass nice and freely. We also have Docolax or Bisocodil, and the uses include to pre-procedure colon evacuation. So if a patient is going to have a procedure, we give that drug, we give the Docolax so we can evacuate and we can cleanse the intestinal tract. And if we have a diagnostic imaging, let's say, we can visualize everything with no stool interfering in the visualization. And that's known as a stimulant. Then we have magnesium hydroxide. We talked about this before. We said before, aluminum hydroxide in the antacids, aluminum hydroxide may potentiate constipation, right? But what does the magnesium hydroxide potentiate as a side effect? Diarrhea. So if somebody has constipation, if they need a stool softener, a laxative, well, we can give that medication too. Magnesium hydroxide, milk of magnesia. It prevents painful elimination. When you're constipated and the patient's defecating and bearing down, it's dry and it's very painful. You could even develop anal fissures because of that. So because of that, we can give magnesium hydroxide. So the therapeutic use is to prevent painful elimination, to promote rapid evacuation of the feces, of the stool, and some nursing interventions and client education. Well, it's contraindicated with somebody who has fecal impaction. If you already have fecal impaction, these medications will not help. All they're going to do is increase the gastric motility and exacerbate the already constipation, the impaction, and maybe cause megacolon or real serious ileus. So again, contraindicated with fecal impaction or a bowel obstruction, same concept, and acute surgical abdomen. That just means severe acute pain of the abdomen. Any of those elements are present, the medication is contraindicated. Encourage regular exercise and promote regular bowel elimination. Movement promotes gastric motility. Fluid encourages more bulk forming capability of the intestine. So because of that, you always want to carry out those non-pharmacological interventions when you're trying to promote stool evacuation. So monitor for chronic laxative use and abuse. I had some students many years ago at the school where I worked at, and one of the girls said, oh, you know, when I'm trying to fit myself into a dress, I take some milk of magnesia because, you know, it helps me eliminate everything and I can squeeze myself into a little dress. So you have to be careful with that, because you guys have probably heard of, let's see, what am I, not anorexia, but bulimia nervosa. Bulimia nervosa, this purging of the body is included in bulimia nervosa, believe it or not. So you have to be careful with that. You have to make sure that your patients do not do that, and you want to report accordingly and educate accordingly. Because if you overuse these stool softeners, in particular the laxatives, your body loses its ability to form its own stool, and you may become dependent on the medication. And provide adequate fluid intake to avoid obstruction. Again, the fluid helps lubricate the intestinal tract. As we form bulk stool, as we form stool, it pulls in the fluid from the capillaries of the intestinal tract so it can help form the bulk. And because of that, you want to increase the fluid intake. And that concludes, guys, the GI medications. I hope that helped out. Please subscribe to my YouTube channel. Please tell everybody about NCLEX Solved on IG. It's nclex.solved. Thank you guys again very much.